glenoid bone loss is critical to avoid complications such as early loosening, impingement, notching, and any instability. There are various techniques available to tackle the bone loss, but that can include autografts, the use of allografts, eccentric reaming, augmented base plates, and custom-made specific instruments. But literature is sparse and scattered when it comes to these techniques and the evidence around them. There are various classification systems when it comes to glenoid bone loss, and the main one, the Page classification, categorizes the bone loss as either contained or uncontained, with uncontained being further categorized as either incomplete or complete. When we think about the Walsh classification, it's talking about the glenoid morphology in terms of glenohumeral pathology within primary osteoarthritis, and actually this was first described using 5mm thick slices on an axial CT image. So our study was aiming at reviewing the various techniques for managing this glenoid bone loss, and in particular when it comes to the use of short-stemmed reverse shoulder prosthesis, and they wanted to present the mid-term survivorship for patients undergoing impaction grafting and structural bone grafting. The clinical and radiological outcomes were reviewed for patients involved in the study. And what we were looking at was, or what we planned is that every patient involved had a CT scan with 3D reconstruction, and the bone defects noted were then classified by the Page classification, which I spoke about a few minutes ago. This CT allowed for accurate assessment of the glenoid retroversion, but then allowed us to plan the graft required, how thick the graft was needed, if there was any version correction that we needed to account for, and whether there was any need for eccentric reaming. So if you look at our chart here, patients received a 3D CT scan. This was reviewed, and they were either found to have a contained defect, whereby they underwent their impaction grafting or eccentric reaming up to about 20 degrees, or alternatively they were found to have an uncontained defect, and then subsequently would undergo either allograft femoral head grafting or structural humeral head graft. So if we look at the techniques for the contained defect, the patient undergoing the surgery, during surgery the gleno was fully exposed, and there. So if we look at the techniques for the contained defect, the patient undergoing the surgery, during surgery the gleno was fully exposed, and there was bicortical drilling as determined by the preoperative CT, the defect was fully exposed and the glenoid rim was preserved. Most cases of these contained defects, the humeral head was used to create small morselized chips. If the humeral head wasn't suitable, or you weren't able to get a suitable graft from it, then we were using tricalcium phosphate granules. And these chips would then fill the defect. The base plate was positioned over the top and 2 derotation screws were then positioned. If before this any excessive retroversion was found on the CT, then they may also need some eccentric reaming up to about 20 degrees. And these are some of the intraoperative pictures. As I said, you would identify the defect, take a graft from either the humerus or the tricalcium phosphate granules, fill the defect with a bit of impaction grafting, and then apply the base plate over the top. What we did find is that the glenoid bone plate, when it was under compression, some of the graft did squeeze out around the edges or around the holes. And these are the post-operative findings for contained defects using the reverse stemless prosthesis. So when we think about the uncontained defects, or what we know is that these defects were large uncontained defects, and they have rim loss and deficient walls, and a prosthesis graft composite was required. If the humeral head itself was used or was suitable, then it could be used as the graft. But in those where the humeral head was not suitable, then a febrile head allograft was used. So the uncontained defects were categorized or subcategorized a little bit differently. And what we found was that if there was significant medial erosion, then a cylindrical bone graft was fashioned from the allograft, and this was prepared sequentially with a central drill and followed by face reaming. A tap was used to prepare the graft to then receive the base plate, and the implant graft was then placed over the native glenoid, with the long tapered screw placed to secure and provide compression. If there was wall defects but without the medialization, then the graft was specifically cut into a wedge shape to fit the defects, in almost like a lock and key type mechanism. So the graft was sawed from either the humeral head or the allograft head into the shape to fit the defect. The graft base plate composite was then implanted back, and if needed, additional screws could be placed, and then the final verso prosthesis was placed. So these are the post-operative radiographs seen when there was a uncontained defect. Our results for this study, there were 37 patients in total, 31 were female and 6 were male. There was a mean age of around 72 years old, with a range of 46 to 88. All the data was prospectively collected, and the mean follow-up was around 3.6 years, but a range of 1 to 10. Indications for surgery, what you can see is there's a large, the most of our patients, a large proportion of our patients was due to a failed prosthesis, most commonly from aseptic failure secondary to some form of infection. But there was other reasons, including primary osteoarthritis or rheumatoid arthritis as well. So of our 37 patients found to have a glenoid defect, 23 of them had a contained defect as per the page classification, and 14 were found to have an uncontained. The 23 with a contained defect underwent impaction bone grafting, either with their autograft humeral head or with synthetic granules as described earlier. Of the 14 that were found to be uncontained, 6 underwent graft implant composite from their own humeral head, whilst 8 underwent allograft from a femoral head. So that in terms of the clinical outcomes, what we found was that the functional scores were collected and recorded in all patients pre and post-operatively, and post-operatively the scores had improved in all functions, and these results were found to be statistically significant with a p of less than 0.0001. So radiological outcomes. All radiological images were reviewed at the final visit. 2 patients did show grade 1 notching, which was defined as an erosion confined to the inferior pillar of the scapula. There was no loosening around the glenoid component in any of our patients within this study. There was no lysis of any areas or no lucency around the central tapered screws. The graphs that we use appear to have integrated fully, but what we do know is that these were reviewed on imaging and this isn't the best option, and therefore to determine that in full it would be best to get a CT. So if we look at a few cases just of pre and post-operatively, so these are the preoperative x-rays and some CT images for a patient. And these are the intraoperative findings for this patient, showing an anteropostural wall defect and the need for a large U-shaped graft, wedge-shaped graft to cover the defect. And then this patient's post-operative findings can be seen there. In a second case, you see the pre and post-operative findings here on the screen, and what you see is there's a lot of superior erosion and medialization of the glenoid preoperatively, and then the post-operative radiological findings following the versoprosthesis implantation. These were the intraoperative findings for this patient, as you can see. And this table looks at the different studies, and comparing our study to them. What you see is that our study is comparable with lower notching noted. Ours is around a 5.8%. And we think that we've got a graft incorporation of around 100%. Our mean follow-up is around 3.5 years, which appears to be one of the higher rates of follow-up. So if we take one, for example, Malus et al., they looked at 45 patients over 2 years. In conclusion, there is an increase in the incidence of arthroplasty surgery, and we know that. And glenoid bone loss is not an infrequent issue to deal with, and can cause any further surgery to be quite complex. We know that contained defects are well managed with bone grafting, but it's actually the uncontained defects that do pose a technical issue. We present a combination of techniques that allow compression loading of the graft from the time of fixation, with any remaining technique reduce the amount of retroversion and the use of bone grafting to correct it to an acceptable level. Overall, this is a reproducible technique with good results. It's not expensive, it doesn't require lots of specialist equipment. And the stemless prosthesis actually preserves patient bone. There are some limitations to our study. It is a prospective study and is only mid-term follow-up. We know that a longer follow-up would be better, and we know that a postoperative CT scan to fully look at the incorporation of the graft would be advantageous. These are some of the references that we used. We have no conflict of interest to declare. And thank you very much.